nice that we're able to keep together as a group. And here we are starting our latest series of sessions of open online briefing on COVID-19. It's actually nearly a month since we had the last session. It was around the 10th of December. And then there were 600,000 reported cases in the previous 24 hours. And that was exceptional. But in the last 24 hours, Catherine, there have been 2.6 million reported cases. And I thought, Catherine, it'd be nice if you just introduced us and get us all teed up, introduced whoever's with us, and then we'll go into the session.
Absolutely. First of all, everybody, Happy New Year. Welcome to 2022. It's great to see all your faces. I hope everybody had a chance to have a little bit of downtime and that you stayed healthy and safe and that you have your families around you as much as possible in this time. So today, first of all, we'd like to say thank you and welcome back to Live Illustration UK. So great that you're here. Chris Shipton, hello. We'd love to hear from you and hear how you are. Great that you are here. Thank you so, so much. Just to let everybody know, we will be recording this. I think you probably already had one of those pop-ups come up and let you know that that was happening, and that it will go on to both David's 4SD website, but also probably into a YouTube stream. So do let us know if you have any concerns about that. Otherwise, the only thing I can say is, David, I want to hand it back to you, but first I want to say, I think those numbers are low. We are not getting an accurate reporting. So maybe I hand over to you to give us some news and some thoughts about what you think is going on.
So Catherine, would you keep an eye on the chat and see who would like to come in and perhaps speak or make a comment? Also keep an eye open in case we have any of our colleagues from the World Health Organization joining us. And if they do come on, we'll stop and give them the space. We'll run it. Also, don't hesitate to remind me if you think we're perhaps going on a bit. Right, let me just share my screen. This is the epidemiology from today. And what I want you to see when you look at the numbers, remember that the colored area, the area under this curve here, is the daily case numbers. And the numbers are here on this axis on the left. And then the solid line is the reported death numbers. These are global, daily. And the real thing to portray is that the case numbers reported to WHO in the last month have shot up, skyrocketed up to this number. And in fact, that's lower than the figure we've just got, which is 2.6. And not only are we dealing with very high case numbers, as Catherine said, we know these are horrendous underestimates because right now it is proving to be extremely difficult in many parts of the world to enable everyone to be tested who needs a test. And in addition, there are all sorts of new developments on tests, which I'll come to in a minute, which make interpretation of the numbers more and more difficult. Where has there been the most marked increase in reported numbers of cases? Well, if you can see it on this, it is that green segment in the middle. And you might remember that the green region is WHO European region, which is the countries of Europe. That's where there has been this massive increase. I don't think anybody here needs me to tell them why. And that's where we're going to focus. But we're going to give a global perspective. We're going to talk about some of the trends that we're seeing, some of the impacts of these trends, some of the responses that seem to make the greatest sense at the present time, the trade-offs that are having to be made, particularly by those in positions of political authority, almost unenviable choices all over the world. The limits to the trade-offs, what is actually the situation in which many decision makers find themselves, often between a rock and a hard place, and then some of the emerging challenges on vaccination and other similar prevention. We might have a chance to look at some of the issues around also treatment and the rest. So let me just talk a little bit about the global perspective and these really rather large numbers of reported cases. Well, it was at the session that we had on the 10th of December when we were talking about the emergence of a new variant, which had been given the name Omicron by WHO, a variant of the original virus that is really much more transmissible than the existing strains that were around, particularly more transmissible than Delta. And at the time, last December, it wasn't clear whether or not this more transmissible variant had the same profile in terms of the degree to which it caused suffering and the risk of death. We also had some preliminary evidence that this new variant Omicron is really quite different from the previous variants and therefore would be capable of bypassing the protection offered by some of the currently available vaccines. And there was some evidence from South Africa, where the earlier reports came in, that actually Omicron might be able to escape vaccine protection. And as the weeks have gone by, there have been quite a lot of pieces of information that have arrived confirming that Omicron is extremely transmissible, but also suggesting that actually Omicron causes disease in a slightly different way. Instead of invading the lower part of the lungs down here, Omicron seems to concentrate itself in the upper part of the respiratory system, back of your throat, and then the main bronchi just underneath where your vocal cords are. And most of its trouble is caused by multiplication in this area and also multiplication in the back of the nose, giving symptoms that are quite like a bad cold. In addition, there's fever. In addition, there's headache, less likely to be loss of smell and taste. And that is more and more what people are reporting with Omicron. It means that the disease is, in general, less severe than the disease caused by Delta. But there's still real uncertainty as to what actually is going to happen when more and more people in more and more places are exposed to Omicron, especially people who are not immune. Either they've not had COVID before or they've been immunized with one of the vaccines. So in these people who are immune, what actually happens to them when, in people who are immune, what happens to them when they get Omicron, but also what happens in people who are not immune. And it's that non-immune community that is still one that we want to look at, and we want to understand what Omicron does in people who have no immunity. I kind of sense from looking at the numbers, particularly the global numbers, but also the numbers coming from hospitals, for example, in UK, also hospitals in South Africa, that actually there is not a lot of severe disease associated with Omicron in hospitals. And so for the time being, I am hoping that this is not going to lead to such serious problems. But there's no doubt that there's going to be an awful lot of people feeling really unwell in the coming weeks. You see, remember, these coronaviruses, they don't just sweep through a population, sort of affecting everybody all at once. They're droplet borne. They tend to occur in spreader events. They tend to occur where people are close together, particularly in confined areas with poor ventilation. Seems that Omicron can also spread quite readily, even outside when the ventilation is not very good. And so it means that you really do have to be careful about airflow. It seems that mask wearing can reduce the risk of being infected with Omicron or giving somebody Omicron. It seems that physical distancing can reduce the threat, but it doesn't completely negate it. It certainly appears that in certain settings, particularly when people are shouting and singing, or when they're doing medical procedures that involve a lot of secretions flying around, then the particles containing the virus, very small ones, can actually be transported in air currents. And so the possibility of some airborne transmission is indeed being considered, but it's primarily droplet borne and primarily therefore happening in quite confined and constrained spaces, and therefore surging up after swirling around in a community, surging up in a fairly precise location, and then perhaps after a period surging up in another location, i.e. I think can expect spikes and surges occurring at intervals for the foreseeable future. My current prediction is that we're not going to see just a bit of Omicron going up and then coming down, and then that's it, it's gone. And I think we've got enough from previous variants to remind us that this virus has a horrible habit of coming back again and again, and we need to be prepared for that. So high transmission, not so much illness, capacity to evade vaccines, capacity to make an awful lot of people ill at the same time. We don't know how much long COVID happens as a result of Omicron. On all these issues, I hope that you'll all be ready to comment, because many of you will have more experience of dealing with this in the last few weeks than I do, especially the clinicians among you. Now, what's it going to do? Well, you can already see it. And those of you in the UK will know that there has been critical incident declarations from a number of hospitals because of a shortage of personnel, perhaps 10%, perhaps 15%, perhaps even 20% absence of staff in certain key areas, leading to really stressed situation in health systems. But it's not just in healthcare, it's in local authority services, it's in rail, bus, security, and then institutions, hospitality, prisons, and the like. We are seeing a real dislocation of services everywhere because of an awful lot of people being ill. What should be done to prevent it? Well, the World Health Organization is very clear, as I just said, the procedures that we use to prevent the spread of other variants should work against Omicron. And indeed, some governments are putting in place quite extensive restrictions to reduce opportunity for contact between people, and indeed also to make it therefore less likely that the virus gets transmitted. Many governments are now looking again at policies for interrupting transmission, where you talked about case finding, isolation, contact tracing, and quarantine. Well, with large numbers of people ill, there is now in many countries a reduced emphasis on contact tracing and quarantining contacts. And indeed, those who are seen to be positive, in some cases are isolating for shorter periods of time, perhaps 7 days and then a negative test, or even 5 days and a couple of negative tests, in order to try to reduce the disruption of essential services. We're seeing, in addition, in many places a shortage of tests, and therefore it's really important that those who suspect that they might have COVID, rather than saying, I won't isolate till I get tested, because if they get tested and there's a delay on the results, they're infecting other people. I've heard a story of an apartment block very close to where I am here, where a concierge got ill and managed to infect quite a lot of residents in the apartment block, spreader, and only got the results of the test after 5 days positive. But by that time, a number of people had got very ill. And so I think we have to be very clear: isolate when symptomatic, confirm with a test if you can, and try to follow the local rules about isolation, and then make certain that you isolate properly. Now, as governments are wrestling with very, very large numbers of people who are sick, clearly some quite challenging choices have to be made. And it's here that we really come to understand why there are elected representatives in many places. It's their job to make the tough choices on behalf of all of us, to weigh up whether or not there should be an absolute effort to try to do everything possible to avoid the risk of sickness and death, or whether to accept that for society to keep going, for essential services to be provided, an element of sickness has to be tolerated. That will lead to some stress in health systems and possibly some stress among people in other specific jobs. But that is part of the price to pay for keeping society going. And it's these balances and trade-offs that are absolutely key and being made all the time right now. And it depends, obviously, an enormous amount on the amount of virus around in a place and what it's doing, and then on the degree to which the public will accept restrictions, or indeed whether the economy will accept restrictions. What is the impact of restrictions or action to ensure isolation and perhaps quarantine on the economy and on society? And I just want to stress that right now, as I see it, we are really counting on politicians to do some really difficult decision making. And once the politician has made the apex decision, then others in different services that are under the control or at least influence of the politician, they are therefore having to do their own trade-offs and risk calculations in ways that take this into account. I think that understanding and being able to acknowledge that there is a political economy here right now, and it's at play, and it's coming in more and more as information about the new variant starts to emerge, and as we're seeing these really tough issues around illness and efforts to maintain economies, this is the time when I think seriously trying to understand the context within which decision makers are working is super desirable. And I'm, together with our team who are on the call today, particularly focusing on that. And it's something that comes up a lot in our discussions with other WHO envoys. Just want to stress that the nature of the trade-offs, of course, is really different depending on what's going on in the environment. Like if many people in a population are vaccinated, then you can be pretty comfortable that if you've got a lot of disease around, that there still should be low levels of sickness and death because the situation is as well protected by the vaccines. But let's say you're in a country, low-income country, where there's much, much less vaccination, where there are a lot of people who are not immune, and the possibility of actually avoiding death is much lower. At the same time, you've got very limited treatment facilities. Your health workers are in short supply. The challenges you face may be very different. And it may be that in low-income countries, there is much more need to try to actually interrupt transmission and slow the spread. Otherwise, you quickly get overload of health services. You quickly get increases in severe illness and death among health workers. And that's why Tedros has been really strong at the beginning of 2022. His New Year message has been, we must get greater equity on vaccine access, because the trade-offs and choices in poor countries are really difficult right now, with both Delta and Omicron moving around. And it is just in no way fair, just, or acceptable that the degree of vaccine inequity that we're seeing at the moment is not only great, but seems to be increasing, because high-income nations are so keen to get their people boosted. Just last observation, there's been quite a lot of stuff in the press about people who are perhaps finding it very hard to accept that they want to be vaccinated, or finding it hard to accept the desirability of wearing a mask. And their activities are not just impinging upon their own health and well-being, but they are also affecting the health and well-being of others. So the non-vaxxed people are seen to be filling up and perhaps even blocking hospitals in some countries. And it's led to a number of leaders to make some quite strong remarks about non-vaxxed people. The Prime Minister of the UK is saying that at least some of those who are articulate and promoting non-vax thinking are spouting mumbo jumbo. President of France was a bit less polite and actually said that he was really unhappy with such people, and Justin Trudeau of Canada even stronger. So I agree and understand. I mean, I agree with the anxiety of such people, but I do not agree with the use of this kind of language. I do not personally agree with demonizing anybody. I think we should assume that many of the people who are not vaccinated have extremely good logic inside their own brains for the decisions that they're taking. And it's not actually helpful to demonize them for that logic. It's likely to lead to them becoming more entrenched and more defensive, when my understanding from talking to people around the world is that if you have a community that is debating whether to accept vaccines, if you go and work with them on their doorstep with local organizations, over time, their vaccine acceptance rates will increase. And that is the way to do it. I mean, many of you who are involved in this, who've been working as volunteers in vaccination programs, have been doing doorstep vaccination efforts. And I think that from my point of view, making the point that to demonize those who are not being vaccinated is an unwise approach. To demonize those who refuse to wear masks is unwise. And I want to try to hold that. Now, some of you in business may be interested to discuss what the implications of all this are for a corporation, especially if there's a wish to try to do daily testing of your staff and so on. We could perhaps talk about that. And it's something that I will be coming back to more during subsequent briefings. I think I'm going to stop my general statements there. I am going to just make a couple of comments about what we're picking up. Australia, you remember how in Australia efforts were made to try to limit the spread of COVID. Well, numbers of cases have increased rapidly, 250% in a week as of the 6th of January, and a shortage of tests and delay of results is making the response extremely difficult. In Brazil, the street carnival was cancelled due to an increase in the number of cases. In India, curfews have been implemented in Delhi and Mumbai, with a 300% increase in weekly incidents throughout the country. This is thought to be due primarily to Omicron. There is also quite a serious problem in Switzerland, with numbers of cases increasing rapidly, record numbers of cases reported by the Federal Office of Health. And by the way, in India, there are some reports that there may be an increased number of hospital admissions, but the key indicator is that not many of these are needing oxygen. You remember the terrible scenes in India when oxygen was in short supply, particularly in Delhi. That same situation appears not to be happening now. Quite nice news from different parts of the world, with nice story from Nigeria working to develop their own COVID-19 vaccine. And there are indeed a number of countries working on vaccine candidates and taking advantage of the fact that the intellectual property has been put into a pool. Chile offering a fourth coronavirus vaccine next week to immunocompromised citizens. We heard a similar account from Israel, and there seem to be other countries planning to go to number 4. But I want to say that WHO is not 100% convinced of the desirability of more and more boosters. And they're saying, well, humoral immunity, that's the antibodies, appear to decline quite quickly. But there is quite a lot of evidence that the T-cell mediated immunity holds up quite well. And so the WHO line is just hang on a bit, let's just try to get as much science as we can before there's a headlong rush to boosters. And that's not least because the more booster buying there is in rich countries, the harder it is to get vaccine to poor countries. So that's my current briefing. Catherine, I'd be super grateful if you could just tell us what's going on. I got a message from Maria van Kerkhove that she might join us. And as soon as we see her, could somebody sing out to me? So Catherine, half time now. Would you like to just tell us how we're going to move on?
Absolutely, no problem. And thank you so much for that, David. So maybe first we can go to Chris Shipton. And Chris, as much as I want to see your drawing, I also want to hear how you are. Perhaps you can give us an update.
Oh, hello. Yeah, great to be back and drawing. That drawing that I did for you last time was virtually the only piece of work I did in the whole of December. So I got it. It must have been Omicron on around the 2nd or 3rd of December, and it pretty much flattened me for the whole of the month. It was like very surprising, actually. So, but yeah, all good now, luckily. And this is now the first bit of drawing.
I don't know if you can see the chat while you're also doing the illustration, but there's been a bunch of people saying, hey, we hope you're okay. So it's lovely to have you back, and I'm so glad to hear. But good to know it really, it's all good. Each of these pieces of data is hugely important, that you had a really rough month.
Well, my whole family was fine. Well,
great.
My kids brushed it off. My wife worked all the way through, but I was sort of wailing and moaning and lying in bed a lot. But I mean, it was no joke. But I'm glad it's over. I sort of suddenly stopped feeling really tired. But I didn't get my booster in time. So my friends who had their boosters, totally different experience.
Oh, interesting. Super interesting. Oh, well, okay, maybe I don't mean to veer off, but I know that we all have a sort of restricted time period. So will you walk us through some of your favorite bits of their illustration so far?
Oh, well,
I actually, for me, I love the new variant wand there.
Well, it's all a lot more, I feel I have a lot more domain knowledge having gone through the entire process. So, it's funny because it's always been an abstract concept. So drawing all of this has been sort of something but it's been very informative to me and my team throughout all of this. That's why we really like doing it for these briefings, because it's been a wonderful way to get a new perspective. But now I've actually had it, and I've done all the PCR tests and had that weird feeling of seeing 2 lines. I've just put a bit of that in there today. And then now I'm trying to moderate my picture of a certain tennis player in out of respect for David's comments about not demonizing people, which I think is very right.
Yeah, no, indeed. Thank you so much. I do think it is entirely reasonable both not to demonize, and it is a piece of what's going on right now. So having it show up here is important. Thanks so much, David. We've had some super interesting questions and people are really engaged. I've sent you probably 10 texts, but we have Gawahir here, we have Yaman, we have Autumn from the Pandemic, Action Network. We have Jane Badham, welcome back. We have Rebecca Cantor, a whole bunch of people. You'll see them in your WhatsApp, but everybody is really keen to hear more about Omicron, more about the vaccines, more about your thoughts. So I leave it to you, and thanks so much. Handing back over.
Okay. When we finish, I am going to ask John Atkinson for some comments. John, let's make sure we don't forget. If you don't mind, but I'm really pleased that Fanilo Heninkaja is here. Fanilo, I can't see you at the moment, but I'm hopeful that you're still connected. There you are. And thank you, Fanilo. And it's really good of you. Are you joining? Well, first of all, tell us where you're joining from, and give us, if you could, in 3 or 4 minutes, a pen picture of what is happening where you are. Over to you.
Okay, so good afternoon, everyone, and thank you very much to give me this opportunity to share with you some comments about the COVID in Madagascar. So I'm Fanilo Ramasmanana, and I'm living in Strasbourg in France, but originally I'm from Madagascar. Madagascar, I think that you know that it's a beautiful island in the Indian Ocean, but also one of the poorest countries in the world. So I just came back from Madagascar, where I spent 1 month and a half for holidays. So I can testify on what I saw during that time regarding COVID-19 in the reality, and to compare on what you can read on newspaper and on social media. So if I just come back on what you say, David, on the general information that you gave at the beginning, one thing that I need to say is that if you look at the number of cases, statistic, I mean, from Africa, I think these are not correct. I mean, there is a lack of data, and we cannot take it as in account. I mean, the reality is totally different. So come back to Madagascar, because I think that the issue that you are facing is really different between rich country and poor country. As many countries in the world, COVID-19 hit Madagascar in March 2020, after some people came from abroad bringing with them the virus. The issue on COVID-19 in Madagascar is not only a matter of health, but also political, and I will explain why. So in March 2020, the Ministry of Culture and Communication, Mrs. Lalatina Rakutunjazafi, as government spokesperson, said on a public statement that the COVID-19 will not be worse than the plague and cholera. So Malagasy people didn't realize the seriousness of the situation, as we are used to deal with plague and cholera. Madagascar got more than 900 million USD as fund to face COVID-19. But until now, there was no transparency on the use of this fund. I mean, some of this fund were used to help the national company for water and electricity, other to buy equipment for private clinic, other parts to buy 4x4 vehicle to fight the virus. We are still looking what's the reason, and some to produce a cure that the president and Radwilna shows as the solution for this pandemic as he tried it on his aunt. And only a very few of that money to help public hospital, health workers, nurses, doctors, who are the frontrunner on such situation. So until now, the World Bank is still waiting for the final report on the use of this fund. So as I said, in April 2020, I think some people, you are maybe aware of that, the president made a very big show to say that they found the cure of the COVID-19 with the COVID organism in Madagascar. So they started to encourage people to take this herbal tea to protect themselves from the virus. There was a propaganda on this cure, and they sent some sample to other African countries without bringing any scientific proof on the efficiency of the herbal tea. As I said before, frontliners were missing of PPIs. I mean, they had to find their own mask and coat to protect themselves. They had to work hard night and day and had delay to get their salary at the end of the month. We don't have appropriate health infrastructure, I mean hospital in Madagascar to take care of people. So we had to open temporary center in some public area like school or sports center. When people were treated in this hospital, sometimes they can face a power cut. So you can imagine that some people who are under respiratory assistance can die because there is no power for the equipment. Another issue also is that in the main town, I mean the capital, Antananarivo, the water is missing. I mean the tap water. So how people can fight against the virus when they don't have access to just water to wash their hands? Okay.
Yeah. So Fanilo, I'm going to stop you now, but just to have another 20 seconds if you've got anything else you want to add before you finish.
Okay, I will just want to speak about the number. The number that we see, as I said before, it doesn't reflect the real situation. Okay. Now the vaccination, because it mean that all country is following to fight against the virus. The president and the authorities said at the beginning that they don't need they don't want the vaccine. Okay.
Yeah.
So now, when the vaccine arrived in Madagascar, the president said that people are free to have it, but he will not do it. So can you imagine how you can convince your population to be vaccinated when the president doesn't lead the example? So,
no, but that's really important. So yes, I think, thank you, Fanilo. This is a really important point, everybody. Number one, the situation in low-income countries is really bad. It's not just Madagascar. We've heard from many of our colleagues throughout Africa right now of situations of hospitals and health centers being overloaded. But then when you've got a national leader who doesn't take the issue seriously, and in this case with COVID organics, as they're calling it, which contains artemisinin, that doesn't help at all. And it's been particularly bad. We've had the same in Brazil, and we've had the same a little earlier, though it's not the same now, in Tanzania. And the other thing that Fanilo pointed out is, of course, that when the health service is not strong, something like COVID really does just knock it into a very bad place. Thank you very much indeed. Fanilo, I've got a number of people who I believe would like to make comments, including one or two questions on long COVID. And so to Gawaho's question, do we have any preliminary indication as to the degree of protection of the existing vaccines against Omicron? Answer, there's no absolute information on this. It's still early days, but it's quite clear that you have a degree of protection against Omicron if you are vaccinated. That protection will diminish over time after you've had your most recent dose. The protection will be greater if you had a 3-dose regime rather than a 1 or 2-dose regime. And there are some suggestions that the protection is better with certain vaccines than with other vaccines, but there is absolutely no clarity, and it would not be a good idea for me to make any statement about any vaccine being better than others protecting against Omicron. The point I want to really stress is that the general picture we're getting is that vaccinated people, when they get Omicron, have less of an unpleasant illness than unvaccinated people, but the degree of protection appears to decline over time. Rebecca is saying that Chile is starting to roll out a fourth booster this week and has started vaccinating children 3 and up. There will be some who perhaps end up with 5 or 6 vaccinations, partly because they want to be able to travel internationally, and they can only do so if they have certain vaccines. This is a major problem. Countries that have based their vaccination program on, for example, the Russian Sputnik 5 vaccine produced by Gamaleya Laboratories, find that people who want to travel internationally go to quite a lot of trouble to get vaccinated with the vaccines that have been approved by the World Health Organization. So far, Sputnik 5 has not been approved. There's a process underway, and we all hope that it will get approved soon, but it requires going through a number of hoops, and those, as I've discussed before, are quite rigorous. Katie Cooper, I'm really interested to know if there are any indications yet on whether long COVID is less among people who have Omicron, whether they are vaccinated or not, or is it simply too soon to say? Are there any of the long COVID experts on this call?
Yeah, I'm here.
Yeah, there you are. Thank you. Off you go. Your turn.
Hi. Yeah, I think it's too early, far too early to say. We're about 4 weeks in the UK, a little bit longer in South Africa and other places, but it's too early to say. I think we can predict that it will be very, very similar rates as with all the others, because it's happened with all of them, and the effects come later, even from asymptomatic infections. So I think we can expect a huge workload from that.
I like you saying, I think we can expect it. I think this is the way to talk. We can expect things. And then if the things don't happen, then relief, great joy. But it's much better to say we can expect something than not. Back to you, Claire.
Absolutely. Can I just introduce my father to you, who was a medical student under your father at the Middlesex.
Hello.
Hello, yes, Dr. John Nabarro. Yes, he was my teacher at one time, and what a pleasure to see you and to remember him. He was a fantastic teacher. Wonderful.
Oh, brilliant. That's rather nice news. There is one of his other siblings is on this call. I'd like to move now to Maria van Kerkhove, who should be with us. Maria, are you here?
I'm here. Hello, everybody. Happy New Year.
Hello, this is Maria van Kerkhove, who is lead on all things epidemiological about COVID at the World Health Organization. Some of you may know she's frequently having the unenviable task of explaining to everybody what all these different numbers and things mean. So I just wonder if with a lot of interest here in Omicron. For example, we were just talking about whether or not it's associated with long COVID in the same way as other variants. And Claire Rayner was saying she's expecting that it will be, but it's too early to tell. Others are interested on whether there's more aerosol transmission of Omicron versus droplet. And still others are wondering what on earth's going to happen with this shortage of tests that we're seeing around the world, and how is that going to affect strategies? So if you felt like it, Maria, it'd be great to have 5 minutes from you on Omicron according to yourself. And thank you again for sparing the time to join us.
It's my pleasure. I had intended to join at the beginning, so I'm really sorry that I'm late. So hello, everybody, and Happy New Year to you and your dads. I love that your dad is joining, Claire. I think that's fantastic. Happy New Year to you all. I really do hope that you had a good holiday and had a little bit of time to separate from this. I tried to myself, somewhat successfully, but Omicron, right? So this variant is incredible. It's incredibly transmissible, but it's in the context. There's factors that are really allowing this variant to thrive. You know, it has the right mutations to adhere to cells and infect cells easily. Other variants had the same thing. It has, unfortunately, we now have immune escape. So people can be reinfected from prior infection. They can get infected if they're vaccinated. Of course, vaccination doesn't prevent all infections or all onward transmission. So this was always a risk, but we do see increased risk of reinfection. We've got evidence that this virus is replicating in the upper airways as opposed to the lower airways. And that's really quite interesting in terms of transmission, but also in terms of severity. The good news is that there is a lower risk of hospitalization, which we've seen across a number of countries, but it doesn't mean that it's a mild virus. It doesn't mean that it causes only mild disease, and it is not the common cold. So if I hear anyone say this, I get enraged because people are dying from Omicron. They're being hospitalized and they're dying from Omicron. And we know that Omicron risk of severe disease increases with age. We're seeing this in preliminary analysis. We see that people who have underlying conditions are at an increased risk of severe disease from Omicron, as well as, of course, people who are not vaccinated. And much of the world is not vaccinated. And so we're in this context. Plus, we have huge amounts of increasing social mixing. And this Delta took advantage of this in the context of wearing masks inappropriately. You know, even in the couple of days that I was away from the office, I think in the last 2 years, I've seen my office, I've seen my house, and I've seen a petrol station. And that's pretty much it for 2 years. And in the last couple of weeks, we were out and about, and I am just shocked at how poorly people wear masks. I mean, I don't understand the point of putting something on your face if it's under your nose, or if it's hanging off your face, or if it's wet, or if I just, you know, if you're going to do this, please wear these types of, masks properly. So we're in a dangerous situation right now because with this increasing transmission, the case numbers are incredible. And I'm sure all of you know people who are infected right now. And the sheer number, the sheer volume of patients so quickly, even with reduced severity, still is translating into a large number of hospitalizations, people who are needing ICU, and people who are dying. So the burden on the healthcare systems, which are already stretched to their limit, which are dealing with health workers who are not only infected, but leaving in droves, due to the sheer amount of pressure and work that they've had over the last couple of years. I've been reading articles over the last few days, the support for health workers around the world has pretty much plummeted. In the beginning, when people were clapping for health workers, when they were giving support and sending kind messages and sending food, that's gone. And so, the health workers around the world have really taken a heavy burden for this, but they're leaving in droves. It's not only affecting health systems, but it's affecting all sectors, as I'm sure you've seen. So governments are making decisions about policies related to isolation, related to quarantine, to balance the risk of onward spread, as well as keeping systems running. Some countries are doing a better job at balancing that risk than others, I would have to say. But our plea is to base your policies on evidence and be very clear about why you're making decisions. If you have different objectives, if you need to make changes in your guidance because you have to keep systems online, fine, but just be clear about that. Do not say that the science has changed and try to fit the science to the policies that you need. This undermines trust. And we have seen this over and over and over again in this pandemic. And this causes a lot of challenges for policymakers, for people who develop guidance, for people who communicate guidance. So we're in for a rough ride in the next couple of months. We have a lot of questions here about Omicron and the peak of what the different size and duration of these peaks that we will see in different countries. In countries where Delta was low, circulation was low, Omicron took over very quickly. In other countries where Delta has been intensely transmitting, it's taken some time. My DG is calling me right now. Has taken some time to outcompete. So we do see some co-circulation. So it will remain to be seen how quickly Omicron will take over, but it is very efficient. And my last point, David, is that this will not be the last variant of concern.
Yeah.
The more the virus spreads, the more opportunities it has to change, and it will change. I'm going to pause for a second and take a call.
No, off you go,
Talk amongst yourselves, and I'll be right back.
Yeah, thank you. Very, just great that you're with us. So that's Maria. And the great thing about Maria is the clarity with which she takes what are stunningly difficult trade-off issues and then lays them before us. And suddenly, wow, you say, that makes such good sense. Thank you very much. I think it was Karen for writing a nice welcoming remark in the chat. Really, really good. Claire, thank you for your comments to Maria. And I just wanted to say to Claire that my sister Annie Appleyard was on. I don't know whether she used to be called Annie Nurse, and she's just there slightly on the edge of the picture. She might know, she was at the Middlesex around that time.
Oh, well, there you go.
There you go.
Fantastic place.
Wonderful. Yeah.
Sorry, David, I'm back. I'm focused.
Okay, Maria, back to you now.
No, if there's questions or if there's anything that you guys have, I mean, I think one of the things we're really also trying
vaccines. I think a lot of people want to know about vaccines and Omicron.
I
think other people would like to know about isolation.
Before I get to vaccines, the vaccines work, okay? The vaccines are incredibly effective at preventing severe disease and death, even against Omicron. There may be some reduced efficacy, but they still work. And I think that's a really important message. So when it's your turn, get vaccinated. But our issue is that we need vaccines for the world. This pandemic is not a problem that is affecting only one country or only high income countries or only countries that have adequate access to boost and boost and boost. We will not be able to boost our way out of this pandemic. So what we are advocating for and stressing is that people who are most at risk in all countries have to be vaccinated. They need their first and second doses, and more people around the world need to be screaming about this. We need to be fighting for this, and we need everyday people to talk to their leaders to say that this is okay to do. But the one thing I do also want to stress is that, we are not in the same position we were in 2 years ago. We have tools, we have therapeutics, we have diagnostics. We don't have enough of them. We don't have them all in the right places, but we have diagnostics, we have therapeutics, we have good clinical care, we have personal protective equipment, we have vaccines. We need to use them better. And what we need people is to not give up hope and not just say, it's inevitable, I'm just going to get this. I've heard a lot of people say I might as well get it now rather than later. And we cannot forget about post-COVID-19 condition. We cannot forget about long COVID. And we have no idea the real extent of long COVID. We don't. We've got some estimates from a couple of countries, but we really don't understand this. And we don't understand the immediate, short term, and then even the longer term, 3, 4, 5, 10 years from now. We don't understand this quite yet. I was asking my teams earlier this week about long COVID and Omicron, given with the replication in the upper airways and what this means. And of course, they're going to be taking that on and looking at that. The short answer is we just don't know. But we can't give up hope. We cannot, we have to stick together. We have to keep fighting, and we have to do what we're doing better. It's not about lockdown or all or nothing. We have to move away from this. I almost feel like everything that I'm saying, I've said 1,000 times. I probably have actually, but we just can't give up. I'm saying this more for myself than I think for you, of like, don't give up, don't give in. Again, I don't believe that there is an inevitability about this virus. I don't believe that Omicron means everybody has to get infected. I still think we need to do both increasing vaccination coverage among those most at risk in all countries, as well as drive transmission down with simple tools that we have. So the vaccines work. I'm not, David, I'm not a vaccine specialist, so I don't have all the details of which vaccines work better, but certainly there are differences in terms of the vaccines. how many doses that you've had, when you've had them in those intervals, if you have underlying conditions, if you're over 60, et cetera. But there's a lot of really smart people looking at that. SAGE will meet again next week, I think on the 19th, I want to say, looking at available dosing, how we get to, the 70% that the DG has been asking us to reach in all countries. And there's just a hell of a lot more work to do. So we got to keep focused. We got to keep positive. Again, I'm talking to myself here, motivating myself here to get out of bed every morning. But I do appreciate this group, and I love chatting with you, David, and you guys always. I don't know about you, but the negative is so much louder out there. Even though it's less, it's just so much louder, and it sticks a lot. It's stickier.
Indeed, we're to keep that positive energy. That's why I love it when we're together. The times that we connect together as the envoys, the times that you come and just give me my often 20 minutes or half an hour of quick stiffener of Maria energy. And thank you for coming today. It's actually so pleased that you had a bit of a break and were able to come out of what must have been quite a deep hole. And I can feel it. Everybody, I'd like on behalf of all of us to thank Maria for giving up some time. We're near the end now, but what a wonderful treat it has been to hear from you. And I'm clapping you anyway, even if, see if it works. Thank you very much indeed. Now, I wanted to just say that Maria did remind us there is an awful lot that is not known about these different versions of the SARS-CoV-2, this virus that appeared at the end of December, beginning of January 2020. And I don't think we should be scared of saying there are things that are not known. There are an awful lot of people making predictions in newspapers and so on. And I often wonder what they know, because they're making statements that have absolutely no basis on fact that I know. So bear in mind all the time, there's so much that's not known, and especially about Omicron. Thank you, Maria, for stressing that. Let's go to John Atkinson. I'd like just a quick essay of what you've heard and any reflections, anything that you'd like us to remember. Then we go to Catherine, and then we say goodbye to all. So John.
I'd like to pick up on the politics, David, as you might imagine. Politics for me is a response to complexity. If everything was known, and Maria was clear with us that it isn't all known, if there was one best answer, if that was all agreed and uncontested, then we wouldn't need a political process. We'd just all follow the plan, and that would be fine. But because we do exist in a complex environment, all these nested, interrelated things in a wider space taking place, we have politics that provides us with the lead. And politicians tend to view the circumstance through the lens of their environments. And often that's the place they represent and the interests that put them there. And they forget at times that their actions are their message much more than their words. So the challenge remains, I think, to see the environment more widely, to see it as global. Omicron and Delta have made very clear to us that you can't just draw a curtain around your country and hope to be safe. It's a global challenge and it needs a global response. And as again, Maria said to us very clearly, it will not be the last, Omicron will not be the last variant of concern. So lifting the eyes to the global environment remains the challenge, I think. Recognizing our interdependence, that's nested set of connections that we all have that makes it work. And if we don't do that, we continue to gamble with the future, David. That's my take.
Thank you, John. Many nuggets. We will record the chat carefully. Many of you quoted things from Maria. If we don't look at this globally, we are truly gambling with the future for ourselves, for our children. I noticed Claire wrote about her children along COVID. Thank you for that. Just everybody, thank you. And for our last words to Catherine, please.
Just to say, I think that summing up with Maria, with John, with David, remember, people are at the center of this. Everybody who gets COVID is a person and their families are affected, and it matters that it's the most vulnerable who are being affected by this, the most poor, the people who have the least amount of resources. And so all of this action that we're taking to globalize this and think about how to fix it, it's really about those people who have so much less than most of us here on this call. And so I encourage us all to take all these messages, but remember, everything you do is to make sure that all the people, all 7.5 billion of us, get the same kind of protection. And I know that is a core of David, Maria, John's, my own messaging, but I want to make sure that's the last thing that I say today. Let's look out for the poor folk. Let's look out for the vulnerable. Let's look out for the elderly. Let's look out for people who have less than us. That's my job in 2022.
Thank you, Catherine. Chris, we'd love you to highlight your picture. We will be planning to meet. I'm careful about being too definite. In 2 weeks' time, same time, we'll be continuing with this format, but we're always keen to receive ideas from you on the LinkedIn group or through other means. Mahika Acharya will become our main communications focal point. We've had a few changes, but Mahika's now been taken on to do this, and she will be our connection point. Over to Chris, please.
Thank you for a fascinating session. I don't think I could really add too much to it. Just quick technical question. It's showing up reversed on my screen.
No, your picture is the right way around. It's the right way around.
So this is
no, it's gorgeous here.
First job of 2022 for me. So it's great to be back, and it's great to be in one of your sessions. And we're all looking forward to hearing more from you over the series 6.
Well, that's nice for you, Chris. Everybody, this is really interesting. Just Novavax, we need to be super careful that is not in any way getting close to the name of a vaccine. And you will check that out just for that. But it's interesting, your picture of Novavax.
I'll make sure with Chris that we check it out. I don't think that Novavax is a name.
I think we're all right.
But it's a really good question, because it sounds like a brand name, doesn't it? Yeah.
So it's a nickname.
Yes.
I've removed it to err on the side of caution.
Yeah, but thank you everybody. And the most beautiful diagram, Chris. And I add that to my selection of absolute bests. Thank you. And with that, we say goodbye. See you again soon. Thank you, everybody.